Good morning. This is Dr. McDaniel at GYN Corner. I'm a board-certified obstetrician gynecologist in New York City, and I'm bringing to you all things health-related for women. Thank you for joining me at GYN Corner today. I'm going to apologize in advance because I most certainly will be coughing. I have a head cold I've been getting over. I'm on antibiotics for the last 5 days or so, but still pretty bad. So I've been hacking, coughing for about the last 5 days or so. So I apologize in advance. So today I am speaking about an uncommon vaginal infection. It's called DESQUAMATIVE INFLAMMATORY VAGINITIS. And this infection was first described in the 50s and became fairly, well known or introduced through journals in 1965. It is, I've seen it a handful of times. Usually I'll see it a handful of times each year. So I'll see it usually maybe 4 or 5 times over the course of a year. And I see vaginal infections. Sorry. I see vaginal infections in the office at least 10 times a day. But DESQUAMATIVE inflammatory vaginitis is a vaginal infection where the name describes specifically what it is. It's due to a chronic inflammatory response of the vaginal tissues that looks like they just kind of die and slough off. And it's usually because the vaginal environment is fairly overcome with foreign bacteria. So it's quite often when someone has a vaginal infection that the infection is due to bacteria that should live in the intestine, stool bacteria. It's set up shop in the vaginal system. And for whatever reason, I can usually recognize it when it's intestinal bacteria, unless it's kind of drowned out by a lot of different bacterial strains. But when intestinal bacteria is in the vagina, it usually has a really bright, almost highlighter, very strong yellow or golden hue to it. And sure enough, with the DESQUAMATIVE inflammatory vaginitis, or the DIV, is described as having a bright yellow discoloration of the discharge, and that it's what we call a purulent type of discharge. So kind of a lotiony, thick lotiony type of bubbly discharge. Usually I always describe it as frothy. And unlike other vaginal infections, it does not have a fishy odor. It will have an unpleasant odor, sometimes like a dead animal. Other times it won't have an odor at all. But what marks this infection as a little different than other infections of the vaginal system is that the vaginal tissues are inflamed. They're usually quite angry looking, red, and you can sometimes touch the vaginal walls with a Q-tip. It'll start to bleed. They're very fragile, and sometimes they'll have what we call petechiae, so you can see almost little blood vessels that are inflamed and spasming at the surface of the vaginal tissues. That's very different from other types of vaginal infections. Now, usually I will assume that this is the case if I see the vaginal tissues are fragile, they bleed easily, it's a bright, thick yellow discharge, bubbly or frothy. And especially if the patient says she's been to a few places and they give her treatment, it helps a little bit, but doesn't really help a lot. So those are usually the scenarios. Now, oftentimes what will happen is we usually will treat with the run-of-the-mill antibiotic that usually treats vaginal infections, so metronidazole, sometimes doxycycline, and it clears it up a bit, but it doesn't completely clear it up. Or the patient will say that it went away, but it came back straight away. So in those cases, it's most often the DIV, DESQUAMATIVE inflammatory vaginitis. Now, you can make the diagnosis microscopically also. You can take a sample and you'll see mostly sloughed off vaginal cells, and very little bacteria because the vaginal cells are just overcrowding the slide. Realistically, very few physicians will do microscopic evaluations anymore because the swabs that we have are really, really good. So the swabs look for DNA, genetic material, so we don't really need to do microscopic evaluations. But if one wanted to, that's what would be seen. That's why it's called DIV. So the inflammatory sloughing dead cells just overrides the microscopic slide. So you don't see a lot of bacteria. You mostly see the dead skin cells. On the exam is how I always make the diagnosis. I do a swab. I send it to the lab. It will usually come back intestinal bacteria. So E. coli, group B strep, sometimes Staph aureus, which is more often skin bacteria. But it's usually the very bright discoloration. You can do a pH swab and it's going to come back with a really high pH because when you have a high bacterial count, it's always supported by a high pH. And what you can do to treat it is you have to use an antibiotic that we don't commonly use in GYN, and that's, unless it's an abscess, it's clindamycin. And what works the best is vaginal clindamycin. So vaginal clindamycin has an anti-inflammatory effect too, so it helps. And the recommendation is I always use it a week, but the recommendation is to use it for a week or to use it repetitively up to 3 weeks. So either 3 weeks straight or 1 week on, 1 week off, up to 3 rounds. And also what can be used is hydrocortisone vaginal suppositories for the anti-inflammatory, for stronger anti-inflammatory, so it's a steroid. I never use the hydrocortisone. I just use the clindamycin. Works really well. If I think it's a mild case, I'll do the week. If I think it's a really severe case, I'll do 2 weeks. I think I've done maybe once or twice the 3 weeks, but I rarely do 3 weeks. And then I always add a diflucan or an anti-yeast, diflucan fluconazole, once a week for each of the weeks that I'm treating the patient so she doesn't have a rebound yeast infection. And then lastly, it's relatively common in women who have gone through menopause because it's more common, or they're much more susceptible because they don't have the estrogen to help provide a layer of defense, a bulky tissue layer of defense in the vaginal walls. So if it's someone who's gone through menopause, you also want to, I guess, rotate that with vaginal estrogen cream. So I would give anyone who's gone through menopause a week of the antibiotic and then a week of vaginal estrogen, week of antibiotic, a week of vaginal estrogen, and then allow her to have at least 4 to 6 weeks of the vaginal estrogen to help provide that support in the vaginal tissues and to allow the treatment to work better and to last longer. So I hope that's been helpful information on DIV, desquamative inflammatory vaginitis. It's not a common vaginal infection, but if you've had repetitive vaginal infections, they don't respond or they barely respond to the usual treatments, then you could ask your doctor to check for DIV, do a swab, see if it's mostly intestinal bacteria, and then to give you the vaginal insert, the 7-night insert with Cleocin, clindamycin, Clindes. It's all the same thing. Thank you very much for joining me here at GYN Corner. Hit the like, subscribe, follow buttons on Facebook, YouTube, and then leave a review on Apple Podcast if you can. Let others know why you enjoy watching GYN Corner, and to encourage them to join the troop. So thanks again for your attention and your time. Have a great rest of your day. Bye.